Hey everyone, welcome to another episode of Let's Talk About Sickle Cell, the Sickle Cell podcast raising awareness of the condition and discussing the ongoing issues that we have to deal with every single day. I'm your host, Janika Lear, and I'm also here with my co-host, hematology nurse practitioner, Maya Bloomberg. Hey Maya.
Hey guys.
So this week's episode, we're going to be talking all things blood transfusions, blood exchanges, the differences between the two, why blood is needed for people living with sickle cell, the need for more black blood donors specifically and ethnic donors, and I guess a variation of lots of other different things to do with blood. Now, I have received both transfusions and exchanges for various different reasons relating to sickle cell. So I plan to share more details on my experience and knowledge, I guess, as we go on. But Maya, I feel like I'm just going to hand over to you as our specialist nurse practitioner to introduce us to this topic of blood and just break it all the way down for us.
Would love to. So it's important to realize that blood is a life-saving treatment in sickle cell. It really is a critical component in managing sickle cell disease. We can use it to alleviate symptoms of pain and anemia, like if you're having shortness of breath or feeling tired. We use it to treat and prevent complications and just overall improve that quality of life for patients. So when we're thinking in the sickle cell setting, what are the indications for a blood transfusion? We have both acute indications, so this is going to be more in that hospital setting, and then we have chronic indications, so those are more to treat the complications. So for the hospital setting, obviously sometimes blood transfusions are going to be needed to treat anemia or a low hemoglobin. We can also see if you have any complications like a stroke or multi-organ failure, or just having a really bad case of acute chest syndrome, because we know your hemoglobin is what's carrying oxygen around your entire body. So if you have acute chest syndrome and you're then having difficulty maintaining your oxygen, even if you're on oxygen, supplemental oxygen, that would be an indication too. When we think of the chronic indications, somebody who has stroke will more than likely be started on blood transfusion therapy because that is the best treatment. For individuals maybe who can't take hydroxyurea, so this could be somebody who has an intolerance to it, or maybe you develop sickle cell ulcers. We know that sickle cell disease alone can cause sickle cell ulcers, but hydroxyurea very rarely can contribute to that as well. Another reason a person couldn't take hydroxyurea is maybe if they have a low platelet count, just knowing that that can drop it further. People who have recurrent vaso-occlusive crises or recurrent pain crises, or they have recurrent acute chest syndrome, that would be an indication to put them on chronic transfusions if we were unable to alleviate those symptoms with hydroxyurea or other disease-modifying therapies. And I'm thinking, well, I think the last indication for chronic transfusions would be somebody with severe pulmonary hypertension as well, because essentially when we are giving blood transfusions, we're decreasing the percentage of sickled hemoglobin. And as a result of that, we're decreasing the risk for that ongoing insult and injury of sickle cell. But there's obviously some risks associated with blood transfusions. It's not like everything is so lolly-golly. So as a result, I think from an acute standpoint, it's important to realize that we don't always have to treat based on a number. Like this is from a patient standpoint where you can really advocate for yourself is knowing what your baseline hemoglobin is. Because if your baseline hemoglobin is around 7.5 and you go to the hospital and your hemoglobin 6.8, I feel like providers always panic anytime they see a hemoglobin below 7 and they'll automatically will transfuse you. But every time we're transfusing you blood, we're putting iron in your system. Now, for a woman, if you have your monthly cycle, you're going to lose your iron that way with the blood loss. But a lot of sickle cell patients get crises triggered by their cycle and then might be on Depo-Provera or an IUD to prevent them from having cycles. So you're not having that blood loss and iron loss as a result. And for a man has no way of getting rid of excess iron. So it's really important to just be mindful about the blood transfusions you're receiving and to not always fixate on the number. So if you feel like you're having oxygenation issues or you have a really bad case of acute chest or any multi-organ failure or a stroke, then for sure you need a blood transfusion. But if you're in for a routine pain crisis, your pain is improving, but your hemoglobin is a 6.5, I would just monitor it. I mean, sometimes Dr. Harrington and I will tell the providers just stop checking labs because it's almost like you're trying to search for a problem where if somebody is clinically doing better, you might not always need that blood transfusion.
Yeah, I think that's so important. I think one of the things that I learned very early on was, my baseline levels of a lot of things, like what's my usual sickle level, what's my usual HB level. And that really helped me in on one occasion when I had a crisis and I wasn't anywhere near to my local kind of like sickle cell unit, so I had to go to a different hospital. And the minute my blood test results came back, they were like, going crazy because my blood was like, my HB was something like 6.8 or something like that. But my baseline is usually around the 7 or, low 7 mark. So, and I think that's different for each individual patient that lives with sickle cell. You might have some people where their average is a lot higher or a lot lower. And like you said, it's not just about the numbers, because even though my sickle level is like 96%, my HB is around the 7, I'm actually absolutely fine. Like, I don't have a lot of crisis pain. As we've mentioned, there could be a lot of stuff going on internally, which I just choose to ignore. But, I'm actually physically okay. So sometimes going by how the patient looks and how the patient feels, I think is very important than, not always focusing on the labs as well. So that's a really important point that you made there. When it comes to, the difference between chronic and just top-up transfusions, so chronic transfusions, we're saying, is mainly given in cases where it's been like a severe complication, like a stroke or something like that. Whereas like a top-up transfusion, what would be the occasion for that? Would it just be like a one-off, someone's not feeling well, or?
Yeah, so that could be treating anemia during a pain crisis, or again, that one really bad case of acute chest syndrome if you're clearly having oxygenation issues, or in somebody who's having multi-organ failure or stroke. I want to touch on the difference between a simple transfusion and a red cell exchange, because even in the acute setting, sometimes we will do red cell exchanges because a simple transfusion, we're just giving you blood. A red cell exchange, we're giving you blood, but we're also removing your blood. So it kind of leaves you operating like somebody with sickle cell trait. And for people who have transfusional iron overload, so say this is a child who had stroke and then they were started on blood transfusions in pediatrics and they transitioned to me as an adult. I have very few adult patients who I keep on simple transfusions because I know that every time I'm transfusing you, I'm putting iron. So when you're doing a red cell exchange, it's kind of less iron that we're putting in. So if you have a person who has really severe iron overload, a red cell exchange is much more appropriate from that standpoint. Did you have a difference? What settings did you receive your blood transfusions in, if you don't mind sharing?
So I've had both, as I mentioned. So my first kind of experience of having blood at all was that I had a stroke. And after, it was determined the type of stroke that I had, I think I had, I don't know the differences, but when I did the Doppler, they basically saw that I had a couple of silent strokes before the one that they actually was like visibly identifiable. So as a result of that, it was protocol that I would have to go on blood transfusions every 4 weeks. I was still around 13 or 14 at this time. So blood transfusions was the only option. And as well as that, one of the issues that we had in the UK, so this was like, I would say 2000 and maybe early 2000s, this was, we never actually had an apheresis machine accessible for sickle cell patients in Birmingham, where I was. There was one in London, and at that point I don't think it was actually accessible for sickle cell patients, so exchanges were done manually, so that wasn't an option. So I was put on chronic blood transfusion, so I would have top up blood every 4 weeks. One of the issues that I had was access, just vein access, every 4 weeks. My veins were just getting completely depleted and just disappearing the whole time. And I didn't want ports. So, there's different access things that they can give you to make it easier, but I really didn't want that. And I'm very much I never like when things just have a never ending date. So for me, it was like, okay, I'm going to go on blood transfusions, but how long do I have to have them for? And it was like, well, let's just see how we go. No one actually said to me, like, if you have a stroke, this is it kind of thing. This is for life. And it wasn't until I think I was on blood transfusions for 2 years. And then I decided that I wanted to stop because that's just the kind of person that I am. I wanted to see how I would go and if I would survive, and I did okay. I did go on hydroxy like a couple of years after because of acute chest syndrome, but I didn't know that, when I moved to adult care and I started to speak to other people that were having transfusions, I realized that everyone that had had a stroke was just on them permanently. And I guess that's when I realized the type of person that I am, of just being like, no, I want to try something different. On the contrary, my blood exchange, the first one I had was actually an emergency manual blood exchange. So an exchange manually was done. I had two access areas in like my main arteries in my groin. One was to pump blood in, and the other one, there was a nurse sitting there pulling the blood out. And it took half a day. I think it was just crazy. So she was there for half a day. I was in and out because I'd had a really bad case of acute chest syndrome and my lung collapse and everything like that. So it was a one-off blood exchange, and it worked. When I understood the difference between the two, I think it really makes a lot of sense. And I think after that, a lot of people living with sickle cell were really trying to advocate for us to have an apheresis machine, because there were just so many people that could have benefited from having a blood exchange, and the iron overload was a main issue, especially for me. That was another reason why I stopped having top-up transfusions. So now I had an issue where my doctor or my hematology team really want me to be on some form of treatment, and the options were either hydroxyurea or chronic blood exchanges. And I after our conversation, I might do hydroxy at some point. But the blood exchanges, for me, one of the main things that I didn't love, other than the iron overload which I had from the transfusions, was the access. I really have issues with my veins and access. What can we talk about the different kind of ways that we can access like veins and things like that? Because I know there are different types of ports that are given to people.
Right. So I'm glad you said that, because I follow someone on Instagram, Sickle Cell Unite, Sarah Jane, and she would post how she would get her red cell exchanges, and they put an access every single time they do the exchange. And you need a big juicy vein because, again, you're being connected to a machine that needs to be able to pump blood in and out with a certain pressure, which I found so interesting and slightly traumatic to have to do frequently, where in the United States, my patients who are on chronic exchanges, we need to have a dual vortex port, and the vortex is capable of being connected to the machine, because not all ports have that capability. But it's important to realize that a port, you have to treat it like your baby, because if it gets infected, it has to get removed. It's not like you can give IV antibiotics, because the antibiotics don't penetrate that plastic device. So I always tell my patients, once we decide to proceed with the port, that treat it like your baby. You're not going to let everybody touch and hold your baby. The same applies for your port. And when you're having somebody access your port, if they're not wearing a mask, or they don't give you a mask, or they're not telling you to turn your head away, that's kind of a red flag. You want to make sure that they're following the appropriate infection protocol measures, because that is probably the biggest risk I find with the ports. The other risk associated with ports that I think is important to mention is that you can develop a blood clot or a thrombosis around the catheter. So I've had patients, they'll send me pictures and they'll be swollen, and yes, a sickle cell crisis can contribute to swelling, but if you have a port and you're having neck or facial swelling and pain in that area, or it might even extend to the arm, that you would definitely want to get an ultrasound and make sure that you're not having that complication. But I typically will try to avoid placing ports in my patients for as long as possible. I have patients who they really do ask frequently for them. And once it gets to the point where they feel like they're being a pincushion and they're just really having issues every single time, they're getting stuck multiple times. Like, I don't want my patients to suffer, but I think it's important to realize that there are risks associated with every procedure, because every procedure is a physical stress on your body, which can trigger a sickle cell crisis. And then just knowing the implications of if your port were to get infected or other complications associated from that. It's interesting how you don't have the apheresis, or you didn't have access to it, because I work between two institutions, and one, which is the public hospital where we see the majority of our sickle cell patients, we have a whole apheresis center. That's where our patients on chronic transfusions and chronic exchanges receive their treatments. And then inpatients as well, we can do the red cell exchanges. But at the other hospital, they don't have an apheresis department. They have dialysis for patients, but we're actually not able to do the red cell exchanges in a timely manner. So I don't want you to think that it's just problems in the UK or in Jamaica. Like even in the United States at a pretty well-known hospital, they're not having the full capabilities either.
I wanted to touch on or ask specifically, you mentioned like, the handling of the poor or treating the poor and making sure that, if anyone is, handling your poor or accessing it, they're doing the right things in order to prevent infection. In the US, is there any kind of rules or protocols around patients accessing their ports themselves? Do you allow it? Do you not allow it? Is it a risk factor? Like what happens there?
Yeah, we don't allow patients to come in. Like I have one patient, for example, who I have, she has home health care, so she can get IV hydration and whatnot in the home setting. So she'll have a nurse access her port, but I also have her come into our clinic or our infusion center to get a weekly Desferal to address the iron overload. So sometimes she'll come in and she'll have the needle accessed already because in her mind, I just had it accessed yesterday. Why am I going to get it accessed again? And we just can't use it. I've tried to just advocate and state that I know the agency who's accessing it, et cetera. But you have to realize from a provider and a healthcare facility standpoint, that could be a risk for contamination. We don't know what was in it. We don't know if they were sterile with it. The same applies when we have patients who are come to our center for the first time with a port. We can't use the port until we have x-ray confirmation unless it was placed by us or we have access to the records because we don't want to do any undue harm for a patient. So we want to make sure that the catheter tip is in the correct location, et cetera. But we definitely don't let patients access ports for them. And even I specialize in sickle cell, but I also specialize in hemophilia and congenital bleeding disorders. And that treatment requires frequent venipuncture for infusion of factor concentrate that babies are born with this, and a lot of them are started on a prophylaxis regimen where they're having to infuse sometimes up to every other day, 3 times a week. So a lot of the moms and parents become trained to access the ports. So I know in certain settings, like if it's an emergency and they're unable to get any access, then in those rare runoff cases, they might allow someone. But generally speaking, the policies, I would be shocked if hospitals would allow patients to access it themselves.
Do you think that, like, as a healthcare provider, I'm asking this question because I know of, maybe it's just the experiences that I know others have had. Like, as I mentioned, I don't have a port, but there are certain rules around ports. Like, if you arrive at a different hospital, then they don't want to access it, or there isn't anyone that even knows how to access the port, which is usually the issue that often occurs, especially in the UK. I've heard it countless times where a patient will be on a ward, they need a transfusion or they need to get access, whether it's for fluids or something, and there's no one on call or available that can access this, and as a result they're being left without fluids, without pain, because there's no other way to get access and they've tried. So in terms of, like, do you think that healthcare providers, or in my mind I feel like, why can't patients get the right training so that if they are in that situation they are able to do it? And I also think that there is some power in, this is just for me, making a decision and doing something and then knowing, okay, this might have happened because it was my fault, rather than someone who is not experienced, doesn't know how to, like, follow these protocols and prevent infection, then doing something and then causing an issue. Like, I'm going to be mad at that person, whereas I feel like I would feel so much better if it was my responsibility or something like that. What are your thoughts around that?
Yeah, I see where you're coming from. When you were saying that there should be training, I thought you were going to say training to providers. I'm like, yeah, but training patients. I see what you're saying. I just realistically, where the ports are typically placed, like I don't see how you could really be extremely sterile. Like I think for emergency cases, maybe like it could be good to be aware, but I feel like those one-off cases are going to happen so rarely that are you really going to remember all of the steps necessary, that I think it's more important for providers to have access to that competency training. Like when I was a bedside nurse, I became chemo certified because when sickle cell patients were admitted to the hospital, I would have to get an oncology nurse to come to my floor to give hydroxyurea, which I thought was so silly considering patients are just taking this at home. So just to prevent delays in treatment, I became chemo certified. And then the same thing with becoming learning how to access ports, we would have to wait for somebody to come up to the floor. So there is competency trainings for providers, and I think they do make them easier and more accessible, but I think you have to want to learn how to do it. And I think depending on what the floor is, but I think there definitely should be more training in the infusion centers. All of those nurses are really wonderful and great from that standpoint. I think it would be good to train the ER or the A&E nurses so they're able, but I just get nervous because if you don't do it often, it's just so easy to forget what all of the steps are to really maintain sterility. And when I say maintaining something sterile, it's just like super, super clean. Because again, we're putting something and accessing something that has a catheter going directly into your heart. So just making sure that everything is kosher from that standpoint is so important. I think it makes me sad because I'm sure there are a lot of patients who kind of suffer at the hands of providers not knowing how to access ports and things of that nature. But from a safety standpoint, I can understand why they wouldn't allow patients to do it at the same time. But I think more training and education. And we were trying to create, like I have my own makeshift sickle cell day hospital where I can bring patients in for IV fluids, pain management, et cetera. And we were trying to look into a subcutaneous hydration therapy plan for those instances where access is difficult, that everything is slow, unfortunately. So if they can't find IV access for my patient, then I can switch the morphine or Dilaudid to be given subcutaneous so they can at least get some relief. But a lot of times they need that hydration. So we're trying to work on a subcutaneous hydration therapy protocol, but it's definitely an issue. And I can see how, unfortunately, patients are left suffering as a result.
Well, I guess more training for, I guess, the right healthcare professionals then in certain spaces. I understand what you're saying in regards to like training would be great in A&E, but again, it's so fast paced and it's so important to, be careful with it because it's accessing that maybe it's not the best place. So safety first for those that I guess are listening and maybe have been in these unfortunate situations. It kind of just, it's protecting yourself from further infection and damage, I guess.
Let's talk about some of the other risks too, because infection and port is a big one. We spoke about iron overload as a blood transfusion risk, but let's talk about some of the acute risks associated with blood transfusions, because I feel like one that as a patient you can advocate for yourself is just if you have a transfusion reaction. So if you don't know what signs and symptoms to look out for, you might not even know that this is happening. So the most important risk, I would say, of blood transfusions is the transfusion reaction, which essentially is just an acute immune response to the blood that you're receiving. So basically, your body is attacking the donor's transfused blood cells. And the most common cause of this is mismatched blood types. This is why we do type and cross match. So your type of blood is either A, B, or O. And then the cross match is when they basically will test the donor blood with the recipient's blood to make sure that it actually is compatible for a blood transfusion. So this is why you always need to get a type and cross match. In the United States, ours are valid for 3 days, but before every blood transfusion, you need a new type and cross match because the more times you're exposed to blood, the more risk there is with developing different antibodies associated with that. So the red flags for a transfusion reaction would be if you develop fever, chills, back pain is a big one, itching or shortness of breath. You might have drop in your blood pressure after it as well. So if you're getting any of these symptoms, you want to stop that blood transfusion immediately. And that's when we'll give the supportive care to manage the symptoms and give IV fluids and probably IV Benadryl and steroids and things to kind of nip it in the butt. But you also need to monitor for complications, just understanding that transfusion reactions can lead to different kidney or organ damage. It can cause something called DIC, where basically your body is consuming all of its clotting proteins, and then you can have bleeding risks. You can go into respiratory failure. So most of the time we do pre-medicate to try to mitigate that, because a fever is actually a common side effect from a blood transfusion, and it's really just a response of the white blood cells in the transfused blood. So if you have no symptoms at all with a low-grade fever, we don't necessarily stress as much, but this is why most of you will get, or at least we pre-medicate our patients with Tylenol and Benadryl from that standpoint. But again, if you were to get the hives, itching, any swelling of the face, difficulty breathing, or the back pain, then that's something that you want to make sure you are addressing quickly. And just speaking about transfusion reactions and the most common cause being just mismatched blood types, I think this is an awesome tie-in for the importance of minority representation in blood donation. We have a critical blood shortage. Like since the pandemic, there's been critical blood shortages all over the world. And minority representation is so important because at the end of the day, it's easier to find compatible blood from an individual with the same racial and ethnic background. I saw a article that was saying that more than 50% of Black donors don't have C, E, or K antigens, which then make them the best match for many sickle cell patients. So just influencing your family and friends to donate, I think, is really important because if you have sickle cell trait, you definitely can donate. It offers a free health check. Like I did a collab with Sharon Peters from Cells of a Generation, who is a group that does a lot of advocacy for blood donation, especially among minorities. And we were trying to debunk a lot of the myths for people who might not want to donate. And one that I was surprised about, but I guess it's not too surprising, is that people think that, God forbid, they were to get into a car accident after donating blood, what would happen to me? But you still have enough circulating blood volume. You end up, it takes like 500 calories to reproduce the red cells that you donated. So you can have a guilt-free dessert at the end. Afterwards, you get a free health check when you donate blood, where they check your cholesterol and blood pressure, hemoglobin, and iron levels. So there really are a lot of benefits besides just saving lives from a sickle cell and other rare disease diagnosis. So I want to encourage everyone to go donate blood. And I mean, there's so many advocacy groups that are spending their time to highlight the importance. So we talked about them. There's a bunch in the UK besides Cells of a Generation, but like in Baltimore, there's the Crisis Care. Which ones are you familiar with? I'm sure you know even more than me.
In the UK, there's Black Blood Matters, which is one of the main ones that do a lot of awareness raising around the importance of blood donation. And there's also one in Nigeria. I think it's important to mention that, you said that the blood shortage, this is a global issue. It's not just like, things that happen in the UK or in America. Like, it's not just the Western world. Blood is so important as a treatment for people living with sickle cell. And as a result, there are blood shortages all over. So in Nigeria, we have Haima Healthcare. They do a lot around awareness and encouraging people to donate blood in the correct way as well. We also, with my friend Jen, launched a campaign called Change the Records, which the main aim was to kind of change the records of the amount of Black people specifically to donate blood. And as you mentioned, the reason why we, in the UK, a few years ago, there was the NHS Blood and Transplant made this tweet about basically just needing more Black people to donate blood. And immediately it just started this whole kind of conversation and argument online about why is there just a need for Black blood donors? Why is it just Black donors? What's wrong with everyone else's blood? And we really had to deep dive and unpack the fact that, yes, there are blood groups, but then as you mentioned, there are so many different subtypes and, there's different layers to blood. And if you are someone that has to receive blood on a regular basis, it's really important that we get blood that is a close match as possible to your specific blood type. And as you said, it is like an ethnic thing. So if I'm receiving blood, I'm most likely going to get a blood that is a close to match to mine from another person of the same ethnic, background as me. So we really tried to kind of put that message out there and spread that awareness. The Change the Records campaign did then get picked up in Europe. So the European Sickle Cell Federation now has a whole campaign around blood donation and changing the records. And it also got picked up by Warriors Unite in Jamaica, and they will be doing a number of different blood drives and awareness campaigns. So people are, paying attention, and we're really trying to raise the awareness. And I know you mentioned some of the biggest kind of misconceptions of blood, one being, people think that they might not have enough blood to give. Another one that we hear, which, is very common, specifically in the Black community, is just around the mistrust of healthcare. There have been so many, instances in the past.
Yeah, of medical exploitation and everything. Mm-hmm.
Yes, Tuskegee, there's Henrietta Lacks. There's so many that people are like, have you read this book? Have you heard of this? And this is the reason why. And I understand that, and I know these things are factual things that have happened, and they have been in terrible, terrible circumstances. On the other hand, being someone that has physically been in a position where blood has saved my life, I've received the blood. I know the blood was there. I know it came to me. It's like, how can you argue with the fact that this is something that is real? I always give people the example of, okay, so you'd have this mistrust in healthcare, but if something happened and you got injured and you needed blood and it was like life or death, are you going to be on your deathbed being like, no, because I don't know where the blood came from? Like, it might, I don't think in that emergency situation, people, when you have a choice, people then have, the opportunity to make it. And for people living with sickle cell and also thalassemia, we don't really have a choice sometimes. This is something that actually gives us this quality of life. It enables a lot of people to be able to maintain as normal life as possible without pain. So I think for anyone listening, if you have never donated blood or maybe you were considering it, I hope that this listening to this episode just makes you feel a little bit more encouraged to go and do that. And for everyone that's doing all the work around it, just keep doing it, keep advocating, keep encouraging people to donate blood. I wondered if you had heard about this new blood group genotype testing. So in the UK, I think it was on the 22nd of January, the NHS they said it's the first healthcare system in the world to provide a new blood group genotype testing, which is going to transform care for patients living with sickle cell and thalassemia in particular. And what it does, it's actually the DNA analysis of the patient's blood groups, and then it allows for more accurate matching for people who need those regular transfusions. So if for anyone living with sickle cell, if you're in the UK, you can now go and get this test done, and it will essentially kind of test down to your DNA, and then it will match it according to your DNA, and it's supposed to be this amazing life-changing thing for us. So I'd encourage anyone who's listening, if you have sickle cell or thal, definitely check out this blood test, go and do it. Apparently it's going to make our lives a whole lot easier in terms of not having those blood reactions and getting blood that is really a match for us. Some good things are coming.
And then just also some tips for people who are donating blood, especially if you have a little needle phobia associated with just getting it. The most important thing, you get used to it over time, but the most important thing is to stay hydrated, because if you're dehydrated, even if you have the vein in the vessel, you're not going to get the blood return. So staying hydrated is really important. You want to consider using heat therapy, because again, if you can dilate the vessel, distraction is key. So putting on a funny movie or a podcast, or just trying to distract yourself, because the worst part is the actual needle insertion, because they kind of do use a larger needle compared to just a needle that they would use for IV fluids, for example, because we have to make sure that it's big enough where the red cells can come out and not get destroyed as a result. But I would just say hydration and distraction are the best methods. Maybe bring a friend with you who can just talk, because once you actually have the needle in place, the rest of the procedure is pretty fast and painless as a result. So I would just, again, encourage blood donation, and seriously, everybody who is dedicating their time and efforts to helping raise awareness on minority representation is really doing great work, because again, blood is life-saving treatment for sickle cell, and it makes that blood donation from minorities even more important. So I'm glad we're trying to bust some of those myths and things that would prevent people from wanting to donate blood altogether.
I did have some questions from the Instagram page around blood donation. So one of the questions was regarding after having a transfusion. So whenever I sometimes have a blood exchange, it leaves me still feeling in pain or having a crisis. My hematology nurse tells me that this is not possible. Is it the truth? So, and I've heard this before as well. The doctor saying you've just received a blood transfusion or a blood exchange, so there's no way that you can actually be having a crisis.
So I have a lot of patients on exchanges, and they'll say it takes them like 1 to 2 days to fully recover. So a resource for my patients in the United States is we have FMLA, the Family Medical Leave Act, which essentially will protect your job if you have to miss work or something related to your sickle cell. So I'll fill these out for patients on red cell exchanges, and sometimes we'll give them a couple days to recover after the exchanges, just because a lot of patients do state that it takes them a day or two to actually start feeling better. But the important thing is to acknowledge, like, is it just those 2 days that you're having pain, but then in between the exchanges, your symptoms are significantly improved? Because it's all about a balance of benefits and risks. So if you're having the severe pain for 1 to 2 days after the exchange, but you're still having the same issues that initially put you on the red cell exchanges, I would wonder, is there any other way that we could optimize you? But it's a procedure. I mean, any type of procedure is a physical stress on your body. You would think that getting blood would automatically kind of juice you up and make you feel better, but I have heard from several of my patients. So I think this is where I always say I only learned so much in school from sickle cell, and I learned the most of just listening to my patients. So I think this would be a good teaching point for that provider, that it is possible. And instead of just turning down a patient's complaint saying it's not possible, kind of do a little research and see if there are other people who share similar experiences as well.
Okay, and we've got one more question, which is I've been on exchanges for almost 4 years. I started off needing exchanges every 5 weeks, and it was really helping. But now I find that after about 3 weeks, I'm starting to experience more crisis pain, and I feel like exchanges are starting to not work for me anymore. Is this something that can happen, or is it just me?
So when we are trying to find what is the best duration or interval for the red cell exchanges, the goal is to keep the sickled hemoglobin or the hemoglobin S below a certain percentage. So this is usually between 30 to 40%, maybe even higher depending on a person's risk factors or what we're treating it for. So if she's having complaints after 3 weeks, I would first do a hemoglobin electrophoresis, which essentially will give a breakdown of all the type of hemoglobin you produce, so we can see what is the percentage of sickled hemoglobin in your blood, and see, do we need to shorten that interval and maybe do it every 4 weeks? Because I do it anywhere from every 4 weeks up to every 7 weeks to try to find that sweet spot for patients. Other things we consider is we'll sometimes have patients on hydroxyurea as well, because again, that increases your fetal hemoglobin, which is much more stable, and that might allow us to push the interval a little bit further as well. And then depending on the pain, I think it's so easy to blame everything on sickle cell that you want to make sure you're looking into other causes and making sure that it's not an autoimmune disorder, or if you're constantly having back pain, make sure that you don't have any disc herniations or things that could be addressed that way. So before we blame everything on sickle cell, just rule out other causes as well, check inflammatory markers. But it's about finding that sweet spot of what works best for you, but it really is guided by that hemoglobin S percentage.
Is it possible for your body to get used to blood? Like if you are having it and it starts off helping you, you have that sweet spot of like 5 to 6 weeks. I'm asking for myself. You have this sweet spot of like 5 to 6 weeks, and then after a year or a couple of months, you notice that actually you don't feel like you can go 5 to 6 weeks. It's maybe around the 3 or 4 mark that you start to feel more fatigue, more lethargic, and it's like you wish you want to have the blood sooner, but it's like your body knows it or almost is expecting it to come. Is that something that can happen like over time eventually?
It's possible, but I also think that pain in general is just very misunderstood. And when we're thinking about chronic pain, I mean, I have plenty of patients who are on red cell exchanges for frequent vaso-occlusive crises because they failed. I don't want to say they failed, but they weren't we couldn't optimize them with the FDA approved treatments that were available, but they still have pain in between the exchanges, and seeing what their levels are, they basically have sickle cell traits. So if that's happening, I want to think, do they have asthma or any oxygenation issues? Because with sickle cell trait, generally this is a benign condition, but we know of plenty of people who do experience sickle cell like pain and other complications. And those individuals, like I get second opinions for patients with these type of individuals, and the first thing I'm doing is let me think about a pulmonary function test and see, are you having any drops of oxygen, maybe doing a sleep study, because if you're waking up in the middle of the night in pain, in my mind, maybe you have large tonsils or a narrow airway that's causing a drop of oxygen that's contributing to it. So I think pain in general is just very misunderstood, and it's easy. It does feel like sickle cell pain, but just having pain and just chronic damage to your nerves can lead to pain outside of just sickling causing the pain. So this is where pain management for chronic pain, it should not just be narcotics, because again, narcotics are just band-aids and turning off that switch in your brain, while you want to make sure you're addressing the nerve pain. So when you're looking at the sickle cell guidelines, which are national guidelines that are really outlining how to treat acute and chronic complication screening and really like everything you need to know from a sickle cell management standpoint, they do recommend different agents to address nerve pain. One of them is a lot of times is a antidepressant, like duloxetine is a big one. And I will always say to my patients up front, because I don't want patients to think I'm being sneaky and putting them on an antidepressant. It's like, no, in the sickle cell guidelines, it clearly states that this medication is beneficial for addressing that neuropathic or nerve pain. But we learn over time that there's different effects. So we have an anti-seizure medicine called gabapentin, which is also really good for nerve pain. So I would just make sure, this is why getting connected to a comprehensive sickle cell center or a specialist who really understands the impacts of sickle cell and knows how to address pain in a little bit more creative ways, because a lot of times patients are just on narcotics, and with narcotics, the more you take, it's just a matter of time that your body gets tolerant to it, which means that you're going to need higher doses to achieve the same level of pain relief. And the way we can slow down that rate of tolerance is by using the lowest dose of narcotics, but also adding the anti-inflammatories or the nerve medications, and kind of just looking at a creative solution to best address someone's pain.
Okay, fantastic. So those are all the questions that I had. As always, guys, if you do have any further questions, please feel free to reach out to us. I respond on the podcast page. So if you do have any questions or any, complications or anything to do with this topic, please do let us know. As always, if you do want to reach out to us for any of the topics that we've discussed on this episode or any of the others, you can find our handles wherever you can listen to the snippets. So you'll be able to see us there, and also make sure you comment and send us DMs. We always respond. So thank you all for listening, and we will be back soon.
Bye.